I'm Dr. Virginia Steen. I'm a rheumatologist at Georgetown University, and I'm going to be talking today about the ABCs of lung disease. Now, I can't see anything, but all right. So we're going to go over a lot of different terminology that I think is important for scleroderma patients to try to understand, and I'm going to try to make it understandable for you, because I know your doctors will be talking about all these different things, and hopefully this will be helpful for you. So we're going to talk about autoantibodies. We're going to talk about pulmonary function tests, or PFTs. We're going to talk about X-rays, or the HRCT. We're going to talk about different kinds of lung disease, pulmonary fibrosis and pulmonary arterial hypertension. We're going to talk about the echo and the PASP and RVSP. Hopefully you'll know all these terms when we finish. And then we're going to also talk about what the right heart catheterization, the RHC, and what the different measures are with that. First of all, though, I think it's really important that scleroderma patients understand that lung disease is now really the main cause of death. 30 years ago, when I first started in rheumatology, we had a complication called scleroderma renal crisis, and we didn't have any blood pressure, any medicine for it. This was very severe high blood pressure, and we didn't have a medicine to control this problem. And literally, anytime someone got that complication, everybody died almost. And we were fortunate to get a very specific kind of high blood pressure medicine, and now that's a very, very manageable disease. And of all, this is from the series of patients out of where I first was at the University of Pittsburgh. And this was a group of scleroderma patients who died out of 3,000 patients here. And I think you can see that almost 50% of them died either of pulmonary hypertension or pulmonary fibrosis. Now, we've already had talks earlier today about pulmonary arterial hypertension that Dr. Fisher gave, and Dr. Silver gave a small talk, I don't know how many of you were there, about pulmonary fibrosis. So you know that these are very important areas. So oftentimes when we look at different features in scleroderma, we look at the extent of skin involvement. So we can look at patients that have limited skin involvement, and those are the patients that are, people mention crest syndrome, but it's basically long-standing Raynaud's and not a lot of systemic symptoms, not a lot of cutaneous symptoms early on, and that is associated with not a lot of skin changes. And people think, oh, well, they don't have any systemic involvement. And yet, this form of the disease, this limited, those patients are some of the people that are at greatest risk for this pulmonary arterial hypertension. And there are other patients with limited skin disease that have very severe pulmonary fibrosis too. So even though the patients with the diffuse form of the disease, the much more rapid progression of the disease with lots of skin involvement, sometimes the Raynaud's isn't even present at first. They have lots of symptoms, tendon rubs, really very aggressive disease, and they are associated with a couple of autoantibodies. Interestingly, one of those autoantibodies, this RNA polymerase III, is associated with a paucity. Very few patients have severe lung disease. So in scleroderma, the extent of the skin disease does not correlate very closely with the lung disease. There are other features that tend to be much more important in predicting whether someone's going to have severe lung disease and what kind of lung disease they're going to have. So we'll just briefly talk about the two major kinds of lung involvement. Pulmonary fibrosis, you may hear it called interstitial lung disease. Basically, it's scar tissue that happens in the lung, in the interstitium, which is the tissue in between the lung airway cells and the blood vessels. And this, on an X-ray, will look like this whitish area. The normal lungs are blackish, and like you can see here, but when you have all this scar tissue, it is white. And so that's what we call pulmonary fibrosis. And the pathology of this, this is a normal lung here, and so these are the air cells, so breathe in and the air comes in here, and this is normally is what we call the interstitium, the lining here, and in here are the blood cells. And so what you're trying to do is to get the oxygen from the air into this area here where you get into your red blood cells. Well, if you have pulmonary fibrosis, this thin interstitium is much, much more thickened, so you have lots of this extra tissue here, and it's all scar tissue. And so that makes it much harder for the air cells, for the oxygen to get into the blood cells there, and so it blocks the diffusion, so to speak, of the oxygen into the body. So the other kind of major lung disease is pulmonary arterial hypertension, and that's a vascular process. And so here there are arteries, and just like you have arteries in your fingers that get thickened from scleroderma, those arteries, when they're thickened in the lung, that makes it harder for the heart to push the blood through the lungs, and so then that puts a strain on the heart, and then that's what makes the right side of the heart not work so well, and that causes the pulmonary hypertension. And the process that is going on as far as the development is normal lungs. These are normal blood vessels here in the lungs, arteries, but when they start to get thickened, as you can see, it makes them stiff, and it makes it harder for the blood to go through there. And then eventually they get so thick that it's really very, very hard for the blood to get through. And it's really important that, particularly in scleroderma, I think, because we know the, quote, disease entity that is associated with it, whereas someone with what they call idiopathic pulmonary arterial hypertension, they don't know they're going to get that. At least in scleroderma, we have the disease process where we know that you have the potential of getting it. And so in here, this is the time when someone is just getting the thickening of the pulmonary arteries before it's so bad, before there is so much pressure buildup that the heart has trouble working. This is when we need to identify these patients. And so what I'm going to be talking about now are some of these risk factors for these different types of lung disease. I just go a little bit more about the compliance of these vessels. Normally, if you have a pulmonary artery, when you have increased blood flow through it, it dilates nicely, but if it's thickened, as you try to push the blood through it, it becomes stiffer, and so it just doesn't expand as well, and it just doesn't work, so the compliance of it makes it harder for the blood to get through that area, and then it backs up and puts pressure on the heart that's trying to get it through the blood vessels there. So the risk factors, we'll start out with the autoantibodies. The autoantibodies, those of you who were just in this last lecture talking about some of the omics and the future of what's going to happen and finding proteomics and genomics and risk factors. Well, we have some of that personalized type of medicine right now in these autoantibodies. And autoantibodies have been around for, learning maybe at least last 20 years. And we've identified certain autoantibodies that are associated very nicely, very closely with certain manifestations. Now, some of them are associated with the extent of skin involvement, and so this group of antibodies on this side of the diagram are those associated with limited, and this is one that are associated with diffuse cutaneous disease. So we have the SCL70 or anti-topoisomerase, and we have the anti-centromere antibody. Those are the two most common antibodies, and one's associated with the classic limited or CREST syndrome, and then the SCL70s, the sort of classic diffuse scleroderma. The other most common one is one that's called RNA polymerase III, and this is the one that's associated with very severe diffuse cutaneous disease, high risk for kidney involvement, but interestingly, a low risk for severe lung involvement. And then we have some of these other ones that are less common, but they're also very important as far as risk factors because they're what we call nucleolar patterns. And an antibody that, when you get the anti-nuclear antibody, when the lab does this, they get a pattern. And so the centromere is one of the patterns. The other antibodies here are speckled patterns, and there's another one that's called a nucleolar pattern. And this pattern is very helpful because almost all the patients with that antibody are at high risk for severe lung disease, either fibrosis or pulmonary arterial hypertension. So this is, by just doing this blood test and knowing which one you have, you can begin to identify the kind of problems that you might have. So patients with the anti-centromere antibody, ACA, they classically have this limited skin disease, the Crest syndrome, and when I see a patient with that, I can really guarantee them that they're not going to get diffuse, severe skin thickening all over their body. And that's very helpful for the patient so that they don't have to worry about those kinds of things. But I also know that they're not going to develop any severe pulmonary fibrosis. Just because of the large numbers of patients that we see with this antibody, we know that. On the other hand, that group of patients is at one of the highest risks for developing pulmonary arterial hypertension. And that can happen slowly over time, and that's why it's important to know if you have that antibody that you need to be monitored and tested for that. The other one, the SCL70, is the one that sort of looks like classic diffuse scleroderma, that all the potential manifestations. But we also know that it has really some of the worst pulmonary fibrosis. And so when someone in my clinic is diagnosed with scleroderma and I get this antibody, we know that pulmonary fibrosis occurs early, and so that the first time I see them, I make sure that they have their pulmonary function tests and then follow them sometimes even every 3 or 4 months to see whether they're developing severe fibrosis. The other antibody that I mentioned was the nucleolar antibody, and again, this does not correlate with the extent of skin thickening. Now, I can tell because there are subsets of this nucleolar that are not commercially available, but in the laboratory, in research laboratories, we can do fancier tests, but they're not commercially available. So I could do these fancy things and come up with another name to this nucleolar antibody. Commonly, if you are Caucasian and have a nucleolar antibody, you're liable to have sort of one antibody. And if you're African American, it's a different autoantibody. But in both cases, the nucleolar antibody is associated with both types of lung disease. So fortunately, this is a smaller subset of scleroderma, only maybe about 10 to 15% of all scleroderma patients have this form of the antibody, but they are at very increased risk. And then the last one, which is the RNA polymerase III that I've mentioned several times. And those patients early on are very, very sick, have very severe disease, and yet they have some of the best overall prognosis. I just ran into a patient that I saw 27 years ago, and she said she came just to say hello to me, to show how well she's doing right now. And many people could hardly believe that she has even had scleroderma. And I can guarantee you she was extremely ill. And she doesn't have severe lung disease, and she's doing quite well. So these antibodies are really very important. So moving on to some of the other tests, hopefully everybody's had a pulmonary function test. This is absolutely an important test to monitor what's going on in your lungs. So PFTs, pulmonary function tests. And these are breathing tests that help us as physicians to know whether if you have any lung disease and what kind of lung disease that you have. So there are lots of different tests that the pulmonary function test lab, but there are really only a couple of them that we in the scleroderma field are interested in, and as far as scleroderma lung disease. So there are two of them. One's called the forced vital capacity, or FVC, and basically this measures how much air you can get into your lungs. And this is a measure of whether there's pulmonary fibrosis. So if you have scar tissue occupying a quarter of your lungs and you take a deep breath in, you're not going to get as much air into your lungs. And so that we can determine how much your FVC is, or your forced vital capacity. And then there's the diffusing capacity. And this measures whether the oxygen can diffuse from those air cells that I showed you and can diffuse into the bloodstream. And this can be abnormal, as you might expect, with either both the scarring process or the vascular process. So the forced vital capacity, you have these uncomfortable mouthpieces, but that's about what we have to do. What you do is the pulmonary function people yell and scream at you to take a deep breath, hold it, and then breathe it all out. And so then that way they can measure how much you were actually able to take in. And that they put the little clip on your nose, and they try to get a mouthpiece that works. And sometimes with all of our small mouths, we have to use the pediatric mouthpiece. And if you're in a center that isn't used to having scleroderma patients, you have to encourage them, tell them to find the pediatric mouthpiece if you have to. The diffusing capacity, basically you're breathing in a small amount of gas, or this carbon monoxide, and then as you breathe that in, you're told to hold your breath, and as you're holding it, that gas diffuses into your bloodstream, and then you breathe it out, and they measure how much you breathe out, and by telling the difference between how much you breathed in and how much you breathed out, they can tell how much was diffused into your bloodstream. And so those are the two major tests. They do a lot of other things that measure obstruction in your lungs, like asthma. We don't usually have that kind of problem. Asthma and smoking is an obstructive process, and that's fortunately not a complication in scleroderma. And this is just another picture of the diffusing capacity, where you can see here, if you've got airspace here and they've got to cross this area to get into the red blood cell, you can see either the red blood cell, if that's thickened, it's going to be harder to get in, or if this interstitium area in here is thickened, either of those will decrease the diffusing capacity. So this is what the PFT looks like. And if you've ever seen it in the lab, you think, oh my God, I'll never understand any of that. And you're not the only one. A lot of your rheumatology colleagues, my rheumatology colleagues, and many of your rheumatologists don't really understand it. But I'm going to teach you how to look at these. So you can read them yourself then. So here are the things, the ones that I've talked about: the forced vital capacity, the FVC, and the DLCO. And usually they're measured like this. This is what they call spirometry. Another one's lung volumes. These are fancier things, and then the diffusing ones. So what they do is to compare this to what's, quote, predicted. And so everybody, depending on their age, their height, their sex, race, they take massive numbers of people and do normals, people that don't have any disease. And so they come up with a formula as to what is expected for someone of your body status, okay? And so that's what this number is here. It's, quote, predicted, percent predicted. And then they give what yours is, and then they give a percentage. And so what it is your number, and the actual number here probably doesn't matter too much for you because it's compared to what large numbers are. So it's the percentage, and the percentage obviously is 0 to 100. When you have these measures, we look at, again, we talked about how the fibrosis is a restrictive process, and so it affects the FVC. And the pulmonary hypertension is one that's associated with a very low diffusing capacity or a low DLCO. But the DLCO can also be low in fibrosis. And so that's why we have to have both of these numbers to tell what's going on there. And the DLCO works the same way. You have a percent predicted in this column, what your number is, and then you have a percentage of what your DLCO is as to what's expected. So normal is usually around 80 to 100. Many people, almost all sclerodermas, have some fibrosis, and so usually if your number's between 65 to 80%, that's considered mild to moderate fibrosis, maybe a little bit more. These aren't exact numbers, and a lot of people have significant fibrosis on their PFTs, but not so much on their x-rays, and vice versa. There's not always a real close connection, but this is a good estimate. And so if you're less than 55% predicted, that really means you have significant pulmonary fibrosis. But the question is, importantly, is whether this is something that needs to be treated. And you've heard about already studies that we are doing and medicines that have been helpful for pulmonary fibrosis. In this circumstance, the timing of when you have pulmonary fibrosis is real important. At this point in time, we don't have any medicines to break down the scar tissue that's already there. And so we have to get it early when there's still the inflammatory condition that is stimulating the scar tissue from developing, so we can stop that process from developing. So that's why it's so important early in the disease, particularly to measure these pulmonary function tests, to do them, as I say, sometimes I do them every 3, 4, 6 months, to make sure there isn't a deterioration. We can't get x-rays all the time. It's just too much to tell. And they're also not that sensitive to show subtle changes. And so these pulmonary function tests can be very helpful. And so if you have early disease, and I mean usually within the first 5 years of your onset of your symptoms, is we still classify as early disease, then if we see changes in these pulmonary function tests, that's when we have the potential to have it respond to the treatments that we have available right now to stop the process from progressing and to have a stabilization. Now, once you've had the disease for a long period of time, you may have chronic fibrosis, and so you may have a forced vital capacity in the 60 range or 65% range, but it doesn't necessarily get worse, and we don't have any medicines to make it improved, and so then we take a slightly different approach. Instead of treating it with aggressive therapy, at that point we monitor it and make sure you don't get other complications, make sure you don't get pneumonia, make sure you don't aspirate, and all the problems with all the GI reflux. And what is concerning to us is that people with scleroderma have frequent aspiration at night when they're laying down and they don't even realize it, and maybe that's aggravating it rather than the disease process. And the other concern is if you get low oxygen, and that's why we do this 6-minute walk test and they measure your oxygen, because if you have a low oxygen, that's going to put a stress on the heart as well. And so these are the things later in the disease that we try to do to try to prevent complications of the chronic pulmonary fibrosis. The diffusing capacity, as I said, the DLCO is something that is lowered in both pulmonary fibrosis as well as pulmonary hypertension. It's sort of the same type of numbers here. 80% is normal, 70 to 80, 60 to 70, we follow it. If you have a very low, less than 60%, and your FVC is normal, meaning you don't have a lot of fibrosis, If you just have a very low DLCO, that puts you at a much increased risk for developing pulmonary arterial hypertension. And so certainly patients in this category are the ones that should be getting the frequent echoes, the yearly echoes, and monitoring their symptoms for the development of pulmonary hypertension. So because rheumatologists are not real good at reading PFTs either, I came up with this little formula to try to help them to understand whether someone's at increased risk for developing pulmonary hypertension or pulmonary fibrosis. So when you see that the pulmonary fibrosis, both the FVC and the DLCO are decreased, both of them are decreased about to the same. So if you do a ratio of the FVC over the DLCO, it's pretty much close to 1, less than 1.4 anyway. But in patients with pulmonary arterial hypertension, the FVC is normal, or if it's not normal, it's close to normal, but that DLCO is really reduced. And so that ratio, the FVC to DLCO, is much, much higher. And again, this is another clue that it doesn't make the diagnosis of pulmonary hypertension. It just gives guidance to being on the alert for developing of pulmonary hypertension. So, risk factors for pulmonary fibrosis or interstitial lung disease are the autoantibodies, SCL70, or this nucleolar pattern ANA, early disease, usually in the first 5 years of any symptoms, the decreased or a decreasing forced vital capacity, and then the abnormal changes on the high-resolution CT scan, HRCT. And these tests, x-rays, chest x-rays, standard things, but they're not very sensitive. You see this white stuff, but you really can't tell how much is going on there or what kind of process is going on there. So we do these, what they call these CT scans, and basically this is this machine. It's a donut hole type machine, and it's taking hundreds of micro cuts. Normally a CT is 3 millimeters, very, very small. And when we do a high resolution, we take 1 millimeter. And so it's really thin cuts, not the cuts, but I mean pictures of your lungs. And they start at the top of your lungs and they go all the way down. And when we look at it, see how much of the lung is involved and what kind of features, whether there's what we call different things, ground glass and reticular changes. There's a bunch of different descriptions, but the important thing is the extent of it and the distribution of it. So again, in early pulmonary fibrosis, we talked about early disease. You need baseline PFTs. If you have an abnormal PFT to start with, you need a HRCT to characterize what's going on. Then you repeat the PFTs on as I say, even as frequently as every 4 to 6 months, and see if the FVC is changing, and then that would be the guide that your doctor would use to make a decision of whether you needed treatment for. Later, if you have chronic fibrosis, probably you just need yearly PFTs to make sure that there's nothing else going on. Occasionally, maybe in 10% of patients who have chronic disease, they will have an exacerbation, meaning they'll have an activation of the lung disease. It's not common, but occasionally it does. And so if you continue to get these pulmonary tests, you'll know, and then you check for the HRCT and see whether there's a change with that. The other things that we talked about during that time is we have to watch out for infections and watch out for oxygen, low oxygen, and the development. If you have severe pulmonary fibrosis, you also are at risk for developing a form of pulmonary hypertension. So the risk factors for pulmonary arterial hypertension, the anti-centromere antibody, is again the highest risk factor, and again this nucleolar antibody pattern. So in both circumstances, you're at increased risk for pulmonary hypertension. Generally, limited scleroderma patients are at greater risk, but many of these patients with the nucleolar pattern have diffuse disease. This is a little bit more common in African American patients, and so that's why we monitor these patients more closely. This is usually something that happens later in the disease. Unlike in pulmonary fibrosis, which is earlier, the pulmonary arterial hypertension may not occur for 15 or 20 years after you've had Raynaud's. And this is probably one of the biggest mistakes that our rheumatology colleagues make, is they think that the patient's done extremely well, they have limited disease, they don't have any pulmonary fibrosis, and they forget about the fact that they are at risk for developing pulmonary hypertension. And so even though you've done extremely well, you're not immune to getting this pulmonary hypertension. Now, if you've had Raynaud's for 15 years and you have pulmonary function tests that show a normal diffusing capacity, then you probably aren't at very high risk. But if your diffusing capacity is 60%, you've got to be monitored closely. So this was from a study that we did in which we looked at patients that had pulmonary arterial hypertension with scleroderma and matched them to a group of other scleroderma patients, primarily with limited skin disease. And we saw that 5 and 6 years before the patients either developed pulmonary hypertension or whether they were controls at a matching time, the DLCO, at a time when these patients were really totally asymptomatic, had normal echocardiograms, their DLCO was 52% predicted. The controls, who hadn't developed pulmonary hypertension, it was 80% predicted. And when we followed these patients, this is the path of what happened to their DLCO. Way back 10 to 15 years before they were diagnosed with pulmonary hypertension, their DLCO was normal. But almost linearly over that 15-year time period. That's a long time for this diffusing capacity to develop. So if we catch you here, when you're down around 50, we can follow you very closely and not wait 5 years later when you come in with right heart failure and now aren't going to be responsive to any medications. So this is the group of patients that we really want to identify, the people with the low diffusing capacity. We want to monitor them. We're doing exercise studies to see whether they have exercise-induced pulmonary hypertension. We're doing a lot of different things to try to identify patients as early as we can because we have so many medications to treat pulmonary arterial hypertension at this point in time, and we want to prevent. And indeed, we have a registry of scleroderma investigators, 20 sites across the country, and we have entered 160 pulmonary hypertension patients with scleroderma. And we have, instead of having a 3-year survival of about 30%, which we had before treatments, we now have a 3-year survival of 80%. So 80% of our patients 3 years after the onset of their pulmonary hypertension are still living and doing well. And this is really a dramatic improvement compared to what we had before treatment, where literally almost everybody died. So this is the heart, and we have the right side of the heart and the pulmonary arteries, and the left side of the heart, and the blood goes into the aorta and out to the body, and then comes into the right side of the heart, and then goes to the lungs. And so what we need to do when we're diagnosing pulmonary arterial hypertension is to determine whether the blood pressure's in the lung, which is the pulmonary through the pulmonary arteries. And the only way you can really do that well is by doing the right heart cath. But we do use echoes, E-C-H-O, echoes. Oh, there's the pretty picture, sorry. Isn't that cute? I didn't do that. Anyway, that's I was supposed to have done that while I was telling you, but anyway. So this is the echo, and again, hopefully pretty much everybody has probably had an echocardiogram. This is a sound wave study where they put a little microphone over your chest, and the sound wave bounces off the structures and looks at the different aspects of your heart, and they can measure the pressures in the heart, which are a reflection of what's going on in the pulmonary arteries. And so this is, I guess, does this have this? Oh, this one doesn't have it. Okay. All right. I can't, wait a minute here. Oh, there it is. Okay. So this is, there's normal. 30/12 is normal. And we have normal systemic pressures. And that didn't work. I had this backwards. Sorry about that. So when you get an echocardiogram, they measure this pulmonary artery systolic pressure, PASP here. Sometimes it's called the right ventricular systolic pressure because it's the right ventricle type of measurement there. And normal is less than 30 millimeters. Borderline with this echo is between 30 and 40, and oftentimes if you see an echocardiogram report, the cardiologist will call a blood pressure over 30 as pulmonary hypertension. They really shouldn't be doing that because the echoes are not, should not be the tool to make a diagnosis of pulmonary hypertension. If it's between 40 and higher, that's certainly suggestive and of concern, and that's certainly the group of patients that we are strongly encouraging having the right heart catheterization done. And certainly if it's over 50, then you absolutely have to have the right heart catheterization done. So problems with the echocardiogram is that it's often not even the right side of the heart is not even looked at on an echocardiogram. So if your doctor just orders an echocardiogram, the cardiologist that does it is used to thinking about the left heart. They're worried about coronary artery disease and heart attacks and all of that. And they don't even look at the right side of the heart because they don't even care about that part of it. But for a scleroderma patient, particularly one that we're looking for pulmonary arterial hypertension, that's one of the most important things. And so your doctor has to actually, in many circumstances, specifically ask the cardiologist to tell him what the pulmonary artery systolic pressure is. And so that has been a problem for us. And other problems include the fact that it's a calculated measure, and so when they do it, they're measuring one thing on the echo, then they have to multiply it and divide it, so a little bit of inaccuracy can have a big difference in the measurement that you have it. So it really is just an estimated value, and we really often have false abnormalities there. And the other problem is that there are lots of different causes for increased pulmonary artery pressures on an echo. And that's why we have to do the right heart catheterization, because that's when the cardiologist can really look at your heart and make sure that the pressures are coming from the lungs, they're coming from the pulmonary arteries. One of the most common causes for increased pulmonary pressures is because the left heart is not working right. Now, we can measure some of that on the echo, when something that's called an ejection fraction. But in scleroderma, unless you're really sick with bad heart problems, the ejection fraction's pretty normal. And the problem that scleroderma patients have is that they, just like they have stiff skin, they can have a stiff heart. And so that's a problem that we call diastolic dysfunction. Anyway, it's a measurement, it's a problem that when the doctors do the right heart catheterization, they can get measurements of that and determine whether the right heart is the problem or whether this other entity is the problem. The most important thing, even though we have lots of treatments for pulmonary arterial hypertension, they don't work in these other kinds of problems. And so they're very expensive, they have side effects, and you really don't want to be treated unless this is the drug and the problem that you have. So shortness of breath. Now, shortness of breath is a very difficult thing to measure, I think. We're mostly concerned about shortness of breath with activity, the kind of breathing that people have when they get anxious or when they have asthma attacks that's just at rest. This isn't usually the kind of problems that scleroderma patients have. And often, I think scleroderma patients don't even recognize that they're becoming short of breath. I think you all have been living with your disease and you're coping with your disease and you adapt to your disease. And, you know, if you don't have to go to the store quite so many times and if you can get somebody else to carry your groceries, you may have just adapted and you haven't even realized that you're not doing as well as you were 6 months ago. So I think it's really important for you to think about the level of activity that it takes for you to do to get short of breath. Can you climb stairs? Can you carry groceries? Can you do things as fast or as easy as you did, not last week, but 6 months ago or a year ago? And so when your doctor asks you, are you short of breath, don't just say, oh no, I'm not short of breath. Think about it a little bit. And as you're going for your follow-up visits, think about it and talk to your doctor about that, because those subtle changes may be really meaningful. So the other problem with shortness of breath is that there are so many different things that are affected in scleroderma that affect a patient's breathing. And one of the measures that we use to document changes in our drug therapy with pulmonary hypertension is what we call this 6-minute walk test. And so you walk for 6 minutes and you measure your oxygen and how far you walk. Well, when you have arthritis and when you have knee problems and when you have muscle problems and you have all the other different kinds of problems that our patients have, that measurement doesn't always clearly suggest that there's a problem. But we've shown that, at least in pulmonary arterial hypertension, that when you have a baseline value and when you develop pulmonary hypertension, when you have worsening of your pulmonary hypertension, that distance that you walk, if everything else is the same, changes. And so we will be encouraging doctors to do sort of baseline pulmonary, 6-minute walk test just to see where you are. It won't be a diagnostic, so it's not like we're going to say you walk 50% of what you should have walked at your age and everything. It's a comparison over time. But there are so many different things. Even mood can affect it, how you're feeling that day. One group of my colleagues in Washington did a study and looked at having the person that was doing the 6-minute walk test telling the difference between walking as far as you can or as fast as you can, and that made a big difference as to what the number was as far as the 6-minute walk test. Another issue with the 6-minute walk test is the measurement of how they measure your oxygen. Now, when you measure your oxygen on your fingers, as most community hospitals and places do, a patient with Raynaud's who walks, what happens to their fingers? They get episodes of Raynaud's. All that blood in their fingers is going to the muscles that they're walking. And so pretty soon they don't have any measurement of how much oxygen, or it's low, and then the doctors get really scary. So there are other ways, and the easiest way is just a marker that they put on your forehead. And so if they're doing it with your finger, you might just bring it to the attention of the pulmonary doctor, the pulmonary lab, that it's probably not very accurate because of your Raynaud's. So this is the right heart cath, and yes, it's an invasive procedure. They put a little catheter into your blood vessel and they thread it into your heart. It's not as invasive as doing coronary artery catheterization, so it's not like they're trying to thread this into the little tiny arteries around the heart. All they're doing is putting it into your heart so that they can measure the pressures that are in the heart. So yes, there are complications. Most of the complications, though, are where they're putting the catheter, and if they you know, if the main vessel that they're putting it into, if it bleeds, that's probably the most common complication. But usually pressure on that is not hard to do, and so it really isn't that invasive. Of all the procedures, you all have had far worse with all those endoscopies that you all have had, I'm sure. The right heart catheterization is really much easier to tolerate. So the measures that we get from that are very important, and I don't expect you to understand all these, but there are several that we look at. The mean pulmonary artery pressure, and that's a very important number. And then there's another one that's called the wedge pressure, and that's a pressure that measures how your left heart is functioning. And so if you have pulmonary arterial hypertension, that wedge pressure should be normal. And if it's not normal, that's suggesting that the left heart is not functioning quite normally and contributing to the pulmonary arterial hypertension. So the other parameter is called a pulmonary vascular resistance. And again, this is just another measure that the doctors can use to determine how severe your pulmonary hypertension is, what kind of pulmonary hypertension is. So all these features are very important to try to sort out whether this is pulmonary arterial hypertension or pulmonary hypertension from other causes. So all patients, this is as far as pulmonary hypertension, all patients should have baseline pulmonary function tests. And I think you should all know what your DLCO and the ratio is. I think that would be very helpful. If you have a low DLCO, or if that ratio is high, then you are at high risk, and certainly that's the time when echoes should be done every year, and if you have any change in your symptoms, then the echo should be done sooner, and if the echo is abnormal, then that's when the right heart cath should be performed. Pulmonary arterial hypertension is a very serious illness, but we do have lots of treatment, and we really think that early intervention is going to make a major difference. So in summary, lung disease is very common and a very serious complication of scleroderma and is the major cause of death in scleroderma patients. Scleroderma patients need to understand the disease and the risk factors and to discuss them with your physicians. I know many of you don't have the opportunity to go to scleroderma centers, and so that your rheumatologist may not be as good at understanding scleroderma as you are. And so I think if you can help them, they're going to be appreciative of that as well. And certainly all of us through the scleroderma rheumatology community are always available to them and to you for help in diagnosing these different problems.